I'm sorry, good morning. I'm Nimi Singh. I'm Division Head of Adolescent Health and Medicine in the Department of Pediatrics here at the university. And I was asked to participate in this panel, I think, for a couple of reasons. One, I've had the recent privilege of being invited to participate in the creation of a more comprehensive model of care for children with autism to be based in our Autism Center here in the Department of Pediatrics, where we want to use a care coordinator model and really provide the community with the first point of contact with someone who is going to be able to guide patients and families as they either discover that their child may be exhibiting signs of autism, or these may be families who already have been told that their child has the diagnosis, has had recent care or has years of care and want a second opinion. Families who are identifying other physical complaints or behavioral complaints that aren't being addressed yet with their children, who want help with navigating the medical system. Families who are having difficulty or need to negotiate the social services arena. And the other piece of it is we're really hoping to then be able to provide a team approach that include experts in developmental and behavioral peds, in the psychological care of these children, in being able to help community primary care providers create a medical home for their patients out in the different communities across Minnesota, and then a small subset of families who may actually want to have their primary care housed at the University of Minnesota with either Dr. Golnick or myself. So the other piece of it is my area of focus prior to looking at autism is working with adolescents around mental health promotion. And that's really another focus of mine in terms of clinical work, education, and research. And I think that's all.
Great. I'm David Wallinga. I'm a physician by training and education. I graduated from the medical school here, but for the last 15 years or so, I've been a full-time advocate for children and environmental health. And the perspective that I carry is in some ways a historical perspective that this conversation really builds on. And I would trace it to the early 1990s when really there began to be a initially small but growing movement of people that were looking at the literature around pollutants and seeing a lot of evidence that they were having impacts on children's health beyond just lead. And there was a landmark study from the National Academies of Science in 1993 called Pesticides in the Diets of Infants and Children. And it wasn't just about pesticides, but really it was about why child development and developing organs like the brain, the immune system, and the whole process of development really left children more vulnerable to these pollutant exposures, oftentimes than adults. And I moved back to Minnesota in 2000, around the same time that a group of physicians, most of whom were affiliated with Physicians for Social Responsibility, but then also including myself, put together a book called In Harm's Way. And what we were trying to do is to say, you know, there's actually quite a bit of science out there in various places around the impacts of environment on learning and developmental disabilities, not just autism, but other learning and developmental disabilities as well. But it's in silos. And frankly, we don't read outside our fields, and so people aren't seeing the whole picture. So we undertook a synthesis piece, and then it was really on a shoestring, and then subsequently developed a pediatric environmental health toolkit for clinicians to use to explain some of these concepts to their patients and to use in their practices. And now that is a free online tool that the CDC has on their website as of about 2 months ago for CME credit. And so this has been a long and ongoing conversation. I now work for a nonprofit think tank in Minneapolis called the Institute for Agriculture and Trade Policy. So for the last 5 years, I've really been building on the idea that food is a really important part of the child environment, that it's not food and the environment, but the environment encompassing everything from us to our food and specifically how it's produced. And so we've put together a number of consumer guides around food topics and why a consumer might want to choose food and produced in this way rather than that way, or food without artificial food dyes, for instance. And I think a lot of that's relevant to what Dr. Rosen was talking about. So just to sum up, my approach is an ecological approach to children's health, where a number of the factors beyond genetics are important potential co-contributors to various health problems, including learning and developmental disabilities, but also important potential exacerbators once those conditions have formed. And that's the way we come at these things.
We're open for questions. We have someone up here.
So I have a question for Dr. Malinga. Do you have any conversation as part of your nonprofit with the school lunch programs in the state?
We do actually. There is an effort funded by the W.K. Kellogg Foundation to work with the people that determine school lunch programs in several cities across the country, and St. Paul is one of them. And we have a local foods program director, Joanne Birkenkamp, who's working with the St. Paul School District around that program.
Good morning. I have a couple questions. One is when a family, I'm a nurse, first off, and when a family says that they've had tests for whether or not they're gluten sensitive or not, and the test comes back negative, what would you recommend to that family in terms of diet modulation? And is that test accurate in all cases or not?
Can you all hear me? Yeah. Well, the first question I would want to know is, what was the test? You know.
Could you please use the microphone? I'm sorry.
It varies in situations. Oops.
Yeah.
It varies, but simple blood test as well as scopic exam.
So, answering that question, I would say there is no test commercially available, to my knowledge, that accurately predicts success of a GFCF diet or any diet. We use tools, we use lab tests, and I think there's a tendency among some practitioners to use a lot of lab tests. And labs can be a guide, but they really don't predict, and that's one area that's hotly debated. So what I would say is, that's interesting, let's look at that. I think, acknowledge that the test was done, look at it. Specifically, if it's a standard food allergy test, it bears looking at. But I would say, look, what is your interest in the diet? What do you hope to achieve by it? What are the reasons why you would think about doing that? Talk about that, and if they are interested, to support them, make sure nutritionally that the child's doing as best they can, and have clear goals and measures to say, how are we going to know if this is successful for your child? My personal opinion is there's really no lab way to guide that currently. So I don't know if anyone disagrees.
So my question about that is, in a sense, you're helping the family to form their own N of 1 experiment. Is that accurate?
Yes.
Could you say a little bit more about that, about what kind of instruction you might give to a family about how to assess the impact of an intervention they're trying?
Sure. So it's a concept, we are used to in research looking, the gold standard being randomized controlled trials of many kids where there's one intervention that we look at across a wide population. We look for a sample size to see that it makes sense. With interventions, specifically with conditions that are so individualized, where the response is individualized, you can do what are called N-of-1 studies. And technically what that means is there is an intervention. It can be a gluten-free, casein-free diet for their child with autism. And you want to try to remove as many biases as you can, which to try to blind it. Now that's very difficult to do, and in practice, that's not what I do most of the time. So I want to distinguish. In a research setting, you could devise a trial for each individual subject where you put them on gluten and off gluten, and on gluten and off gluten, using really medical foods. You would have difficulty, you wouldn't be able to want to tell what it is, and have measurable outcomes in terms of, have the family help define the outcomes. What is it? Is it sleep? Is it focus? Is it stims? Is it language? Whatever the things they want to improve. Is it stomach symptoms like constipation or diarrhea? Have these clear outcomes. So in practice, the way this works for me is we still help them define individual outcomes. We can't blind the therapy, but we do have them try to have a succinct time period to try this intervention without any other biomedical intervention. It is naive to think there's going to be no other change in their environment during this period. That's impossible. You're not asking them to stop ABA or to stop going to school or to stop new interventions. And to be frank, many families continue to integrate other biomedical interventions at the same time. So these are very difficult from a research perspective, but I think the point is we're trying to work one-on-one with each child to have definable outcomes and measurements so that we learn what is success and what is not. And sometimes that's going on the diet and back off the diet and back on the diet to see what the differences are.
I might add a little caveat to that, that I agree with all that, and I think, thinking about an issue like this, children are so individual. So it's important, to even look at the kind of, flip side, if you will, to that, which is I have families come in to me and say, we really did that diet, and we did it for 6 months, and we did not see behavioral changes. And I can say to them, with the evidence we have right now, we cannot tell you that across the board for all children who have been diagnosed with autism spectrum disorders, this has been shown to have behavioral improvements at all. And like Larry said, if there's a potential for this having some use, likely, as we know with autism, it's more likely to be in a subset. So I think it's important to also think about, the family input and the potential guilt around something like this, and also reassure them from the evidence from that approach. And there have been some studies done on the gluten-free, casein-free diet, but a lot of them have methodological weaknesses, and that's a very challenging study to do. Susan Levy in New York is coming out soon with some data on a larger study, but we don't know what that'll show, and I know she had a lot of challenges to also doing this study, so we should be getting some more data in the next few months, but we don't know what that will show.
We have a question in the back here.
Good morning. I had a question for Dr. Golnick. I was surprised to see how many physicians referred out for ABA as a CAM, and I was just curious, were you surprised to see that? And what do you think, did they have knowledge of it and that's why they referred out to it? Or what do you think that high referral level for that was?
And forgive me if I'm not following your question exactly. The actual asking them about whether or not they would recommend ABA, I've got to get the percentage exact. I think it was around even 50 or 60%. Now, I did not say intensive behavioral intervention. I said applied behavioral analysis. It might have been better to say something like intense behavioral therapy. So potentially a general family practice physician was not familiar with that term, applied behavioral analysis. Certainly speaks to the fact that we need greater education around autism and effective therapies Absolutely. I also asked physicians about what I called their competency, but it was a whole mix of things that they said. I have the capacity to care for these kids. I have the resources. And physicians who were more likely to encourage applied behavioral analysis also were the ones who reported that they had a higher self-competency. So that certainly fit together well in the study. I did not present that today to say that, that all makes sense in a picture, that some people are feeling more that like they have a greater capacity to care for these children. But I think probably in general the biggest message for that is physician education.
I am wondering, and any of you can answer this, if you recommend organic food to the family that has a child with autism, and then also perhaps to the typically developing child, and perhaps even then to a pregnant mother who is carrying a fetus. Would you recommend organic food?
I think that's me. And I can't tell who's asking the question, so I don't know who I'm looking at. Can you raise your hand? Oh, in the back. I think it's worth thinking about how the food is raised, whether it's certified organic or not. And for those of you who don't know, the USDA now has a specific set of criteria around what is considered organic with third-party certification. That means somebody's gone out to the farm and checked to make sure that that's what the farmer's actually doing. So some reasons to think about a certified food product like organic. What does that mean? Well, for meat production, like chicken production, certified production means that they're not adding organic arsenic to the chicken feed, which is something that is done for most other chicken produced in the country. So I have a lot of concerns about organic arsenic being put in chicken feed. We know a lot about arsenic in various forms. Inorganic arsenic's a known carcinogen, so yeah, it's definitely toxic. And some forms of arsenic now have been identified as hormone disruptors. So if you're concerned about that, then yeah, that might be a good criteria. Organic meat also is not raised with antibiotics added to the feed, which, like arsenic, are really just used to make them grow faster. In terms of plants, and I think probably all of you know this, organic production means no synthetic pesticides derived from petroleum or natural gas. And most produce items raised conventionally, that is with pesticides, have pesticide residues on them, at least one and often more than one different pesticides. And for example, a food product like peaches, the average peach raised conventionally could have 6 to 8 different pesticide residues on it. So for the dirty dozen, so-called dirty dozen, the top 12 produce items that tend to have the most pesticide residues, it might very well be a good thing to buy them organic. Now you could also buy them from Farmer John down the road or through a CSA and have a pretty good idea of what practices that farmer's using, and that might be a less expensive way to go and get the same sort of result that you're looking for.
Just wanted to make a comment on that too, because someone asked me during the break, if you were, has anyone ever studied, and I think the answer is no, an organic casein diet versus a non-organic casein? Is the problem the casein? Is it that it's non-organic? I think it's a fascinating question, and I think it leads to, what advice we give parents in general. And you asked about pregnant women, very important. I think in an ideal world, we would want to provide food sources that were as locally grown, as non-toxic as possible. I think we all agree that's the ideal. It is tough in the real world in terms of affordability and accessibility. And while there are not and may never be clear health studies where I ate this food and the next week I was better, that's very hard to do. I think intuitively we know that by removing additives to foods, and those are pesticides and organics are important, but it's also high fructose corn syrup and trans fats and all the food dyes and additives. I thought it was nice that physicians were tolerating their patients not having additives in their foods. They should be actively encouraging that. So these are messages that we do seek to provide. But I think we do have to be mindful of the societal limitations on that advice. I think that's tough.
One other quick note. There's actually 30 years worth of studies looking at something called the dilution effect. And this is the phenomena that conventional production, by selecting for yield, in other words, I'm a farmer, I'm going to institute practices that give me more of what I'm growing rather than focusing on other things like nutrient density. Right. That if you look across a wide range of different produce products dating back decades, that there's been a decrement in the nutrient density for things like vitamin C and some of the antioxidants and some of the other nutrients too. So buying food raised organically or under more sustainable models may actually give you a nutrient boost when you're providing nutritional support to these kids.
I think we have a question in the front.
It's actually a follow-up question. When you are trying to, how do you track the success of an intervention? When you talk about the N of 1 study, do you have a tool that you use to track that so that it's not just parent input? I mean, I'm a parent of 5 kids, and middle son has autism. And I know how difficult it is to track some of these things. And sometimes I think I'm really on the mark in terms of, how often he stooled in the last 2 weeks. And unless I write it down, I don't know for sure. So what tool do you use with families?
That's a good question. Do you want me to start with that? So that's an area that there are a number of people around the country who have developed or are developing sort of outcome measure tools. I'll tell you what I do, and I'll tell you what else is available. So I don't use a standardized measure because I don't think it's flexible enough for primary care practice and for most busy families. So what I try to do as we have, just like we do in education, we have goal-setting meetings and conferences. And I sit down with the parents and say, look, I'm going to track and you're going to track, and we're going to make a list of the top 3, 4, 5 things you want to see improvements with this intervention or these interventions. And what I would love for you to do is, I know you're busy each day, just write a little note, brief little note, today, X, Y, Z. And when I talk with you and when I evaluate your child, I'm going to do the same thing over time. Obviously, you're going to have many more endpoints than I'm going to have. And we're going to sit down, or we're going to talk, or we're going to email, or whatever it takes to do. This is where coordination comes in and accessibility comes in. And we're going to track that over days, weeks, months. Some of these interventions take longer than a few days to see an impact. But you're right. You look back and say, 2 months ago, what did I do? I don't know. Maybe it made a difference. So it is important, and we do these goal-setting conferences and follow-ups. There are some checklist items that have been developed, like the Autism Research Institute, the DAN people, have a parent rating form. And what they do is they actually publish aggregate data. About X% of parents said this intervention was effective for my child. It's interesting, not particularly scientific, but interesting. And so they have a checklist you could print out and use. It's pretty complicated, I think, and I don't know if anyone uses it, but some practitioners do.
I'm going to make one more comment, too. I appreciate the question. The questioner is even working with me, and my team is here today. I'm in primary care, and so we're working on how do we make that something that's easy to use in a 15 or hopefully 30-minute visit together. Mm-hmm. And so we really use, right now, a basic calendar that we're working on. How's it easiest to choose your target behaviors together as a team and then monitor those? We give them a rating scale. But I did want to make one comment that I think that it's really important for medical practitioners to team up with more of the behavioralist providers. They do a really excellent job of this. And I had such a great discussion with one of the behavioral providers in town here last week, where they actually have a completely separate section where they coach families in terms of how do I think about the changes I'm going to make and how do I measure them over time. So it's really even separate from the therapy. And I think that behavioral therapy providers do a great job of this. So this is an area where we could really team up with them to say, okay, if we're going to try one of these interventions or a medicine or anything, let's see how you guys do it and use that.
Just another kind of follow-up question to that. are they always, when you're looking for data points, are they typically behavioral data points, or do we do, a lab data point, in addition to that? Or do we use a pain predictor? I mean, do you have sort of a same set of sequences for?
It depends. Because it's so individual, I would say it includes, yes, the answer is yes, all of those. For some children, it is digestive markers, how often they go to the bathroom. For some, it's pain-related. For some, it's how many ticks or stims they have in a given hour or day. For some, it's seizures. For some, it is language or communication or understanding. For some, it is behaviors or opposite. I mean, you can define it in any of those ways. It would be nice if over time we could look at some of those markers that are below the surface and have more objective data. I will pick up on what Allison said, which is when you look at Jill James' work, the stuff I presented about B12 and folic acid, what I love that she's starting to do is partner with Doreen Granpichet, who's a behaviorist, with a CARD program to have, and these are extensive behavioral observations, but in research settings and academic settings, it would be wonderful to have that kind of data.
This is a question from outstate Minnesota, from Long Prairie. Has any work been done with kombucha or kombucha, spelled Kombucha, a Chinese or Russian elixir that cleanses toxins or pollutants from the liver and intestines?
That's a good question. Yeah, kombucha is a fermented drink, if you will. Tea. It's a tea. It's from a green. I know they can't hear you, but it's really a fermented food, like a tea source. It's made as a tea, an infusion, which is purported to have high antioxidant levels, probiotic levels. So while it's one of these sort of functional foods that's pretty hot right now, the answer is no. There's no research that I'm aware of.
Hi, I have a question for Dr. Rosen. I am also a parent of a child with autism, and I don't want to get too personal and too detailed, but he's 10 years old, and his main issues are attention, social difficulties, and withdrawal. So there is no real gastrointestinal issue, except for a peanut allergy. So my question is integrative medicine something that you would recommend, even though there's no real GI problem there? Or does the GI piece have to be kind of like a starting point? Mm-hmm. And the second part of my question is, we are currently considering attention medications, mm-hmm. So I want to know if the two things exclude each other, the attention medication and the integrative medicine.
Great.
Thanks.
Great. No, thank you for bringing that up and for sharing your story. What you are struggling with is what many, many, many parents struggle with. And when we talk about integrative approaches, the point is we do look at blending those, and it's to take the first point about gastrointestinal disorders. There's no study that shows that you need to have problems, observable problems with the GI tract, meaning things that you would see. To have success with some of these interventions. Perhaps your child is one of those who is in a different group who has more focus issues. And so there are interventions that have been looked at to help with focus and support. There are some, when they look at children in the attention deficit literature and in the autism literature, there have been implications with iron and zinc and other micronutrient deficiencies. Thyroid function is certainly something people will look at. There's also a therapy called neurofeedback, which is a form of biofeedback that has been studied in children with ADHD and higher functioning children with autism who have attentional issues. It involves meeting with a therapist once a week and doing a variety of mapping electrical activity and perhaps modulating that using computers. And it's found to be, in some studies, equally as effective as medication over a long period of time. So there are things that are worthwhile exploring, omega-3 fatty acids being one, and again, looking at diet and nutrition as a support for brain function. Additionally, you asked about medications. One is not, you don't need to do one or the other, and that's really the point of integrative medicine, is I do have children in my practice who I use both. And I guess our hope is, I have very few parents who come in and say, today's the day I want to start medicine. And I understand it's a bias with the kind of practice that I have, but even with many of my colleagues, that's not usually the parent's first choice. So it's important to explore complementary approaches. However, sometimes that is the best answer for that child, and there are ways to integrate. So, does that help? Yeah.
Do we have more Greater Minnesota questions? I see you carrying around a couple of. Can we do the Greater Minnesota question?
This is a question from Crookston. If these biomedical treatments are effective, why are so many of these organizations, DAN, ARA, IFM, listed on Quack Watch as being questionable?
You want to take that one? You can go ahead.
Dr. Jeffrey Bland, who is a nutritional biochemist whose ability to pull together basic science and clinical research is probably incomparable of any of the sort of educators out in the public field, is also on Quack Watch. And his science is grounded in basic cell biology, molecular biology, genetics, anatomy and physiology. That is the same science that biomedically trained practitioners studied in school, only he has connected the dots in a completely different way. And what I would say is it's very uncomfortable to be asked to take on, again to use the terminology that Dr. Rosen brought up, to be asked to take on a paradigm shift when there's a philosophical approach that's really the mainstay of a particular discipline. And then there's a group of questioning practitioners or scientists who say, let's start from a different point. That feels very uncomfortable. And if I could summarize the difference between the two philosophical approaches, traditional Western biomedicine starts with disease developing and then collecting observing the signs and symptoms and determining whether or not somebody meets full criteria for a disease, at which point then we move forward with drugs or surgery, typically. And if patients do not meet full criteria for that disease, we often do not have very much to offer. And yet, there's clearly, it's sort of again that iceberg approach of we function only at the level, the traditional Western biomedical practitioners function at the level where things are manifest, but we're not very well trained or asked to think about what are the precursors, what are the physiologic imbalances that preceded full-blown disease, and are there ways in which we can identify that through signs and symptoms or even laboratory studies such that we can step in and intervene prior to that process being left to go its natural course and then turn into full-blown disease. And that is the focus of one of the organizations that Dr. Rosen brought up was this Institute of Functional Medicine. And the reason why they use the term functional medicine is because they really talk about how if you go back to understanding how the body functions at a basic level to maintain balance, and then understand what are the kinds of factors that cause the body to go out of balance, and what is required in order to help it return to that balance. Are there environmental toxins or exposures that are interfering with normal enzyme processes, for example? Are there nutritional deficiencies that are not allowing the cells to do everything that it needs to do? And that is not the way traditional medical schools teach physicians to think about what's going on in the lives of their patients and families. And we know that there's a deficit there. There's tremendous gain in the Western biomedical approach for many diseases, and we made incredible strides in so many areas. But the subset that we're talking about who are left frustrated are the ones who go to their doctors and say, I have fatigue, or I have concentration problems, or I have aches and pains, and the conventional laboratory studies come back negative. And then the patient's told there's nothing wrong with you. And yet the patient knows something is out of balance that wasn't there, say, 6 months prior. And the concern is, how do we, in a responsible and scientifically grounded way, still stay with the patient and meet them where they are and try to explore with them ways in which to try to restore balance in their body, even though what's going on with them isn't labeled as a full-blown disease in a textbook. So those are the folks who choose to take that on end up on Quack Watch. Now, that's not to say that there aren't folks out there who are doing seriously questionable things and are involved in treatment modalities that are that have been shown to do harm, and that's critical for us to be vigilant about that. So again, goes back to Dr. Rosen and Dr. Golnick's slide of that grid where you really have to look at safety and efficacy and make sure that you're not doing harm. But to even be willing to meet families where they are when they don't meet full criteria for disease can sometimes make you suspect within the traditional biomedical field, because that's not what we were traditionally taught to take on, and yet that is the growing bulk of symptomatology that's really emerging in the population, this sort of increasing prevalence in chronic illness. And sometimes people meet full-blown criteria, sometimes they don't. And yet, I personally, as a practicing clinician, don't feel comfortable saying to a family, I know you're suffering, but I didn't learn about your disease, so I can't help you. I need to understand better as a clinician, and I want to work with them and explore what is available and what might support their system in a responsible and scientifically grounded way to the best of my ability.
I would just, that was very eloquent. And without,
Sorry.
without defending any one group or practitioner, I would say I would encourage the questioner and those who have similar questions to read about the history of alternative medicine. There are various guides around there, and understand the socio-political climate in which those questions are raised and those observations are made, in which wholesale professions, which may have to do more with economic or socio-political considerations, are defined as quackery. So you have to think about that in its full context.
Acupuncture was considered quackery 40 years ago. It's the mainstay in many orthopedic clinics. It's being recognized in many areas of medicine. Actually, biofeedback used to be considered quackery, and it is very much recognized as one of the more effective treatments for migraine headaches, for chronic pain syndromes. And so again, some of it is just a matter of the research having to happen, and it depends on where we are in the timeline of history. So,
And I just want to refer to a conversation that I know that you and I have had previously that I think the N of one study concept is really critical to, which is that autism is not a single disease entity. It's a whole collection of causes. And so it's difficult to say ahead of time, this will or this will not work for a particular child.
I think Dr. Goldnick and Dr. Rosen, I'm here, both referred to studies, but I'm interested in how much information there is about what parents are using, and whether, if you have any good references or sources, or want to give a little more information about what alternative means parents are using, how much information there is about that, and their responses about it. And also, if you could add, what's a good history of alternative medicine?
Sure. I mean, right off the start, my mind goes right to the parent surveys that we both referenced there. the parent surveys that say that over 50% of children are being treated. And I'm certainly happy to share all those resources with you. It would take a long time to tell you all the exact names. And those go through, kind of, and it's all parent response surveys and some convenient samples. That means people who just came into their clinics. But anyways, it goes over the reasons why and other things like thinking about, it was in one study, parents who had a higher level of education, and I think maybe even were older, were the ones who are more likely to be using those. So, it goes over demographic factors of what might be associated with it. Other than that, do you have any specific, internet? Yeah. Sure. And I think I have some of them down, and Larry has some of them down in the handout that you have there, but I'd be very happy to share all that information.
There are, I'm trying to look it up right now because I can't remember the author's name, but you can always email me and I can send you. There are two particularly very good histories of alternative medicine in the United States, which go through sort of discipline by discipline and trace, it's very illustrative. As far as what parents are doing, that was something we looked at in our survey that I presented with the 92% use. We looked at what the different things were. Some CAM surveys will talk about global terms, about this is in our study, what the parents were using. There is a database, again, on the Autism Research Institute website, ARI, where they compile parent-reported efficacy. But it's a list of all the different therapies. So, and it doesn't necessarily say how many are doing each one, but that is one other resource.
And we can save you the trouble of getting all of our emails. We'll post the relevant links and documents on our website.
That's great.
I have two questions for Dr. Malinga, and they're both practical and one is very short. What was the website where we could find the toolkit for pediatric environmental health?
I believe it's also the CME course is at the CDC, ATSDR component of the CDC, but the toolkit itself is at www.igc.org/PSR. And I think that'll also give you a linkage to the specific CDC website.
Thank you. My other question is a practical one also. I work with families who don't have much money, and I'm interested if you could list for us the best bang for your buck in terms of organic, which would be fruits and vegetables that have the least pesticide loads, and the ones that have the most nutrient-rich loads.
Well, I think the best bang for your buck isn't necessarily organic. It's to buy in season, either at the farmer's market or through a farm share, and then freeze. Like I go to a U-Pick'em organic berry farm up near Forest Lake, and then just freeze boatloads of strawberries, blueberries, raspberries, etc. And my goal this year is to learn how to can and do some of the other things, because I actually do think that's quite economical. If you are going to pick organic and you want to shop at a supermarket, if you look at our website and look for the Smart Produce Guide, we have a whole series of these consumer-oriented fact sheets called the Smart Guides. So we have a Smart Guide to meat and dairy products, a Smart Guide for produce, a Smart Plastics Guide. And those are all at iatp.org.
I have to put in a plug, I'm sorry, for David's website. The Institute for Agriculture and Trade Policy. It's a wonderful, wonderful website for any of you who are interested in understanding better the environmental health issues. And more importantly, it's not just about raising your fear about, oh my gosh, we've created such a mess. They really have wonderful practical guidelines and things that you can do, to change your own home environment, things that you can advocate for. I was just speaking with a couple. We were concerned about the possibility of solvent exposure in the schools, and what can we do about that? And this website allows you to really take it from the individual level to the family, to the community, to the advocacy level. You can go as far as you want, and I just really commend David and his colleagues for the work they've done, because it's all there. So I for any of you who are interested, I really invite you to check out the website.
Thank you.
I have a question concerning diagnostic tools used with autism, and in particular, I'm interested in PET scans, positron emission tomography, and also MRI. Where do those two fit in the diagnostic framework?
They're both still considered experimental in research settings. No one is using those in any regular fashion diagnostically. I think, there's certainly a great interest in developing those kinds of tools for early diagnosis and recognition, and also in terms of subtyping. If we can say this type of brain leads to this type of function, and how can we intervene? I don't know if you're familiar with Daniel Amen's work in PET scanning. He is a physician who's looked at PET scan patterns in ADHD and trying to subtype ADHD. And he writes about integrative therapies with nutrition, et cetera, but his interest is mostly in diagnosis. It is not currently recommended that all children with autism receive an MRI. It's only under certain circumstances. But I think, as we go along and understand more about the links between anatomy, physiology, and behavior, I think you may see more of that.
Hi, I'm a psychologist here at the U, and I wanted to make a comment, an observation that we see from time to time, and then get your take on how to advise families in those situations. We see families who have been advised to go on a list of complementary alternative vitamins or supplements, and they have the sense that it's working, or the child is slightly better, but meanwhile they're paying $500 a month, for this long list of interventions. How would you advise a family like that?
Well, I really like what Dr. Rosen said, was we really have to think of nutritional supplementation as not lifelong but temporary, and at the same time really trying to maximize nutrition through whole foods. And so Robin, I hear you. I mean, and the other piece that Allison brought up was families being reluctant to not spend that money because then they feel guilty that they're withholding something that might be of benefit. And that's where, again, who's to say that it wouldn't be worth doing a trial off all of that for a month after the child has been on it for a really long time, for example, and track if there are any significant shifts. So again, I think we're in the practice of healthcare for clinicians. We're very reluctant once we've started something to remove it, even when we're not convinced of its efficacy. I mean, we do this with antihypertensive medication for adults. We do this for typically for psychotropic medications for mood disorders. Once it's been started, we're reluctant to stop, even if it's not clear that it's really had benefit. And I think we have to do more of that and allow, again, the family to track whether or not there are differences.
Would you advise starting one by one as well? Because, I mean, they have 10 different ones, and maybe it's one that seems to be making a small difference and the rest
It would depend, again. So much of it would be depend on the story, the symptoms, what we think the main physiologic imbalances are. So omega-3 fatty acids are an example of a nutritional supplement that is being written widely as being supportive in a number of chronic inflammatory conditions, and it's because it supports the functioning of the cell membrane. Now, your body's made up entirely of cells. They all have cell membranes. It improves receptor function. It's hard to argue that that wouldn't be of benefit for many people with illness, and probably a bunch of us without overt illness. But some other supplements, it may be more questionable. So again, I doubt there's a one answer approach depending on what the situation is. But I completely agree with you. I think to some degree it may be unconscionable to not address the $500 a month issue.
Well, here's the challenge is that we want to see, and we do see the substitution. People say, oh, great, I don't want to use medications, but I'd like to use something more natural. So there's a pill-for-pill substitution, if you will. It's just something you get as a prescription and something you get at GNC, your vitamin shop. You know, I think that within nutritional work or integrative work, it's a different concept than the one pill, one disease model. So many of these therapies are synergistic and meant to be used together. On the other hand, what I've observed, and it's taken me years to observe this, in the first few years I didn't, but now that I have families for over 10 years that I've seen with young children, first diagnosed later on, there's patterns that develop. They're really gung-ho. They do everything they can. They spend a ton of money. And over time, they tend to burn out. And they tend to stop spending so much money. And now look, some of the times it's because they don't see results with their kids. Sometimes children do improve in ways and they recognize I don't need all these things. And so I do spend a lot of time working with them to peel back in a way that acknowledges anxiety and guilt and all of those things. So,
Can I share a visual metaphor that I heard yesterday that I think really gets at this core issue of something of a clash between different paradigms for thinking about these issues? The speaker yesterday said, thinking of the child as a whole system, a child with sort of a patent system that's working well is like a river contained behind a dike made up of a lot of smaller sandbags. And with some of these kids, maybe what we're looking at is a total dike collapse, and all these sandbags are strewn around. And the conventional medical paradigm might say, let's find the one sandbag that we can put back to recreate that dike. And I think what you just said in a different way was, we found that we need several sandbags, and they actually work together to create that dike. So it's almost the wrong question to say, which sandbag should we pick? I just find that to be a really effective metaphor.
And another piece of that is there a way to transition towards a more whole foods approach that will support and allow decrease of some of the supplements, if not all of them?
Right.
So again, it's like getting back to sort of what we evolved to take in as humans to the best of our ability.
Unfortunately, I'm afraid we've run out of time for today. I want to thank you, the panelists, for a wonderful discussion and our presenters. And I want to thank the audience, both here and Greater Minnesota. Please be sure to fill out your evaluation forms, either here on paper or online for Greater Minnesota. And again, thank you very much for what I think has been an outstanding series this year.
I've got a running. Present us with